It's about OHS and how to differentiate OSA from OHS. And to summarize this condition, it's basically dealing with an obese, body mass index more than 30 kilo person who has daytime hypoventilation with a PCO2 more than or equal to 45, and no other obvious cause of hypercapnia, central, pulmonary, neuromuscular, metabolic, or chest wall disorder can be identified. So OHS is really defined as this. And approximately 10 to 20% of patients with obstructive sleep apnea have OHS, and it's important to recognize it. The difference when it comes to OSA is that these patients are dyspneic. A sleep apneic patient is never dyspneic, unless he's dyspneic just because of his morbid obesity. They don't present with dyspnea. Daytime hypoxia, as you know, is not common in sleep apnea. So any patient who is hypoxic during the day, it cannot be just sleep apnea responsible for it. You also get signs of cor pulmonale very often, right heart failure, and it's usually diagnosed by exclusion. And therefore, you need to exclude a chest wall disorder, a neuromuscular issue, chronic obstructive pulmonary disease in an obese patient often. Once you've got those out of the way, you can say convincingly that this is probably OHS. Suspect it on borderline oximetry on these patients. So someone who walks into the clinic with a saturation of 92, 93% and has never had a pre-existing history of lung disease, that's a pretty good sign. It's not a good screening tool because we know many of these patients have some underlying lung disease. Rarely, these patients have a PO2 more than 70. So you would, and you should land up getting a blood gas done for all of them. And the serum bicarbonate, which is a very good test, and is how many of our nephrologists pick it up actually, a serum bicarbonate more than 27 milliequivalents per liter has an excellent sensitivity for OHS. And that would mean that if the value is more than 27, the chances that it is OHS are high. But if it's less than 27, you're more or less ruling out obesity hypoventilation syndrome. What are the lung functions like? So when this patient comes in with a low saturation, you're not going to get obstructive airway disease if they have classical OHS. Low vital capacity, these are obese patients. Small tidal volumes, you will notice when they do their volume time curve. Higher respiratory rate. And abdominal fat deposition compromises diaphragmatic function and therefore thins the patient's diaphragm. What do you need to achieve for them? You need to get their CO2s down, both awake and while asleep, and prevent them from desaturating at least below 88%, because we know anything going below 88% would reflect a PO2 going below 55, which is a critical level at which tissue hypoxia can occur. And so that's where you'd probably want to keep them, relieve their breathlessness and their hypersomnia, and reduce the concomitant or the complications of hypoxia, which are secondary polycythemia, pulmonary hypertension, and cor pulmonale if present. The treatment therefore focuses on weight loss. Oxygen alone is not recommended. Weight loss is the most important treatment. Oxygen alone is not a great idea because they will start retaining carbon dioxide even more. Tracheostomy is a very, very I would say, stretched procedure in these patients, and only those who are refractory to NIV, really morbidly obese, where you cannot even manage with NIV. And pharmacotherapy, medroxyprogesterone, for a short-term use can be useful. If they get an infection, they come into the hospital, you want to discharge them with better carbon dioxide, you can give them short-term medroxyprogesterone, but definitely not a great long-term option. Positive pressure, just like in sleep apnea, is the treatment of choice. And to quickly, in 5 minutes, summarize how the pressures or the treatment differs, is if you cannot achieve immediate weight loss, which is really difficult to achieve, barring bariatric surgery, and even in the workup or the prelude towards bariatric surgery in some of these patients, you will have to give them positive pressure till they are, operated, and even after surgery for a period of time. So if the patient is stable, but remember this, and this is to many physicians and respiratory physicians listening in, and PCO2 is less than 55, CPAP is more than enough. And this is a mistake people make. Some people have this misconception that if the carbon dioxide is high, they have to be on non-invasive ventilation. And this is not the case. Advanced age, a very elderly patient, poor lung function, when I mean poor lung function, a COPD patient especially, and a CO2 higher than 55, think about NIV. Any day NIV or CPAP over a lifestyle change. This is not a disease you can treat with just a lifestyle change. You can do oromotor exercises, tongue exercises. You can give them a diet. You can tell them to change their lifestyle. But once you're diagnosed with obesity hypoventilation syndrome, positive airway pressure is absolutely essential. There is hardly a difference between CPAP and NIV, and there's no difference in treatment failure between these two conditions either. No data to suggest that one is superior over the other. And about 70% of OHS patients have severe sleep apnea, so CPAP should be just fine. If there is no severe coexistent OSA, so the AHI is below 30, NIV may offer a benefit in these patients. Remember, CPAP costs less than non-invasive ventilation. The adherence is similar, and NIV requires a little more resource for titration and equipment training. If the classical OHS patients gets admitted to your hospital, there's usually no time to do a sleep study. And these patients just come into ICU hypoxic, they're put onto non-invasive ventilation, and they're overnight better. About 20 years ago, when these studies were done, people could actually check for mortality when discharged without positive airway pressure. Today, fortunately, no one is discharged without that. But the mortality was significant in those who were discharged without PAP. And today, at 2 years, the discharge is even less than 8% at 24 months. These patients do remarkably well on PAP. So what we normally do in OHS, unlike OSA, is just discharge them on NIV. Don't do a sleep study. They're hypoxic. There's been an infection that's probably triggered their arrival into the hospital. Plan a sleep study later. And when you do that sleep study, if it is severe OSA, they can actually be shifted to CPAP. So they may want to take the machine on rent for a month or 2 months or 3 months, do the sleep study, and then decide whether to buy CPAP or NIV. So to give you a brief algorithm before I end, ambulatory stable obese patient, low probability of OHS, just do a serum bicarbonate level. Bicarbonate below 27, OHS, highly unlikely. Serum bicarbonate more than 27, get a blood gas done. And if there's hypercapnia, proceed to a full sleep study and titration. In patients who cannot afford it, or where you're very clear they have a severe sleep apnea, clinically at least, do a split night study, half the night study, and half the night CPAP titration. They're still not doing well, do another night of NIV titration. And your sleep technician or engineer that you worked with has to understand this well. It's very important in clinical practice to have a sleep technician or engineer who really is on top of all this and who understands this, especially simple tests like overnight oximetry, which are grossly underused, in my opinion, in a respiratory practice, can make the difference between prescribing oxygen to a patient while they sleep vis-a-vis not prescribing it. And so many patients get unnecessary oxygen while asleep, and so many patients get it at the wrong flow rate. So overnight oximetry, titration, very important studies. And of course, if you have severe OSA with OHS, CPAP titrated to the pressure should be fine. And if hypercapnia and you have mild moderate sleep apnea, you can use NIV. So, and this is acute OHS, of course, just apply the NIV. The patient comes into the ICU, apply the NIV. If the pH is crossed 7.3, you can add oxygen if required to keep the saturation above 88. and discharge on NIV, later do a polysomnography. And when you do the titration, have oxygen. If the patient has been discharged on oxygen, do titration studies with and without oxygen to understand whether that patient actually needs oxygen or just non-invasive ventilation at night. Okay, and NIV, just a few words as I close on understanding settings. This is important because we all deal with CPAP and OHS, CPAP for sleep apnea and OHS. And I think a few important messages that different manufacturers have different ways to label expiratory pressure. There will be one machine that says it's PEP, there's one says PEEP, one says EPAP. All these mean the same thing when it comes to non-invasive ventilation. They're all expiratory pressure. Likewise, inspiratory pressure is positive inspiratory pressure or IPAP. I would strongly refer you to an article. Don't confuse IPAP with pressure support, because if you work in an ICU, pressure support is what a lot of critical care people know about. Respiratory physicians deal with IPAP much more often. So setting up home NIV, look at this article, beautiful article, which tells you the difference between IPAP and pressure support. Basically, IPAP minus the EPAP or the PEEP is the pressure support. So when a patient is in the ICU, on NIV, on a ventilator in the ICU, and you want to move into a portable machine, you need to understand this well, because the same settings are not applicable there. And I would urge you to read that article. EPAP increases the mouth pressure, and COPD patients have intrinsic EPAP. So observe the effort on any given EPAP. If the patient is labored, okay, or the effort is too low, if the EPAP is too low, the effort is going to be high labored breathing, delay inspiratory trigger. So you may want to increase that EPAP. Perioperatively, and we have at least 2 surgeons on our panel today, 3 surgeons. OHS is a risk factor for difficult mask ventilation and difficult intubation. And any anesthesiologist will tell you this. The ramp position with a head and torso elevation to a 25-degree tilt improves ventilation, oxygenation, and the glottic view. Always prefer a regional anesthesia and block for any patient with OHS if you can do it. And if you have to give general anesthesia, extubate the patient when fully awake and seated ideally, and give them post-operative PAP. This becomes a huge challenge with major head, face, neck surgeries and neurosurgery. But that's why a multidisciplinary team deciding what type of anesthesia and how the patient should be extubated onto what can help tremendously. Probably HFNO will play a big role in some of these patients, provided the surgery is not very near the nose. So to conclude, recognize OHS, differentiate it from OSA well, very clear ways to manage this in practice, and we shouldn't make these errors. Arterial blood gas, if you have the luxury of getting it done easily at your institute, or a venous bicarbonate, for those of you who don't want to prick your patients too often. CPAP, remember, is as good as NIV in most patients with obesity hypoventilation syndrome. Understand the NIV settings from the article I mentioned to you, especially the difference between pressure support versus IPAP. And finally, manage OHS very well, perioperatively as well. Thank you very much for your attention.
Thank you very much, Dr. Sujit.
Thank you.
It was a wonderfully given an overview about the obesity hyperventilation syndrome. And we'll have the questions after the discussion. And I would like to welcome Dr. Srinivas Kishore, who is the Director of ENT AG Hospital, Hyderabad, to give an overview about drug-induced sleep endoscopy, DISE. We call it as. Over to Srinivas.
Yeah. Can you hear me?
Yeah.
Okay. Can you see my slides?
Yes.
Yes.
Right. At the outset, again, let me thank ResMed for a fantastic initiative, and thanks for bringing us all on on this platform so that we can discuss our problems and learn from each other. Drug-induced sleep endoscopy is something that we've all been talking about for a few years now. But what I want to be talking to you in the next 10-15 minutes is its usefulness for planning and prognostication, depending upon what kind of therapy you would want to use, whether you want to use a PAP, you want to use a mandibular advancing device or surgery. Actually, drug-induced sleep endoscopy helps us to do so. And in the next 15 minutes, we'll try and see how so. And I would always like to start with this particular slide that today in 2021, when we talk about sleep apnea management, we have completely moved from the concept that we're going to offer one kind of treatment to a particular patient. It's not the hammer and nail thing anymore. You're not going to hammer every patient with a CPAP, or we as surgeons not going to do that. The ultimate goal of any procedure, whether it's old or new, is to provide both the clinician and the patient the confidence for a successful outcome. And since personalization, which is the name of the topic today, it is all about understanding that OSA is a journey, and this person would require some modality in these 4 that I've spoken about, and PAP therapy, or in conjugation with each other, so that we can improve the outcome of these patients. Now, for example, this particular patient, if you see, looking at him, it's very obvious that, you know, this could be one of Dr. Sujit's OHS patients with a severe AHI of about 93. And if you were to allow to give him the CPAP, if you give him a CPAP blindly without evaluating the patient, he may not pick it up, because if you were to put a scope in his nose and see these bad anatomical static abnormalities, which would make it very difficult for PAP to work. So until the advent of DICE, we have not had a method of identifying the specific site of upper airway obstruction. Now we are now able to treat the specific site of upper airway obstruction, which is responsible. Now, more often than not, it's just not a single site, and it's just not as easy as it is shown on this video, where it's only the epiglottis which is causing the problem. Now, DICE helps us to improve the localization, and it also helps us to understand the character of the upper airway, because it has been tested that there is significant inter-rater reliability and test-retest reliability. So it is, there is a lot of evidence to show that, you know, DICE actually works to help to, it helps to improve our treatment choices. The most important thing is that, does it actually help us to improve our outcomes, which I'm going to talk to you a little later. Now, it's also important that DICE has to be done at a particular period of, it has to be done for a minimum of about 15 to 20 minutes. Otherwise, just going in and out like a check scopy will not help, because there is a lot of literature that again says that the patterns of obstruction change with time. So unless you go through the entire time, you will not be able to understand the behavior of the upper airway. And it's also important that you quantify your depth of sedation by using either target controlled PCI or by using BIS. BIS is very easily available, which actually helps you to understand the depth of sedation. Now, if you really look at this video here, if you look at the behavior of the airway at a BIS of about 82, reasonably open airway with, look at the airway when the BIS is about 74. So it's also very important to look at the airway and look at its behavior at different BISs, because each BIS value corresponds to a particular stage in your sleep. Now, we've slowly advanced ourselves to what we now call as advanced DICE. wherein we are actually performing a full polysomnography while the patient is sedated and trying to look at the behavior of the upper airway, as you can see here. So the patient is on dexmedetomidine. You can actually see the video on the flexible scope there, the portable one there, and you can see what's going on while in the PSG while things are going on. Now, there are lots of new technologies that have come in wherein we combine all the data into, and you can fuse the data and put it all in a single nutshell to understand all the parameters in a single short video. Now, does really DICE help in planning and prognostication? One is a concept called interventional DICE, wherein we know that most of our patients are mouth breathers, and this is at a BIS of about 70. And when the patient is mouth breathing, if you perform a DICE, intraoral DICE, you would actually see whether the palate is obstructing because of the tongue, or is so on this side, on the left side, you can actually see the same patient's DICE intranasally. And if you look at on the right side, this is an intraoral DICE showing why there is a lateral collapse here. What we would think is that the tongue is actually folding on itself, but that's not true. If you see the nasal DICE, you would see that the lateral pharyngeal wall is so lax, making the tongue fold on itself, giving rise to that kind of a picture. So these patients are having, who have significant lateral collapse, are having poor prognosis in surgery. Now, when you have a patient with significant obstructions happening caused by tongue base, if you do what is called as an Eschmark maneuver, which would actually taut the lateral wall as well. So here in this video, you can see that the jaw thrust has been released and the tongue base is falling backwards, as opposed to when the Eschmark was done, the whole airway, including the tongue and the lateral wall, look very splinted and the airway is open. Now, there is again a lot of role of DICE in mandibular advancing devices, but for want of time, let me just quickly bypass this. There's also a lot of role of DICE in positional therapy, so wherein you can actually change the head and trunk position or the head position alone to see how the behavior of the upper airway is during different positions. This is a trick that you can all use. It's called Mesopharyngeal Airway while you're doing DICE to actually see if correcting the proximal obstructions, especially at the level of the nose and at the level of the palate, can improve the obstruction lower down. If you can see in this particular patient, the airway is being splinted by the nasopharyngeal airway. And if you slowly withdraw the nasopharyngeal airway, which actually represents a proximal surgery in the level of the oropharynx or in the palate or in the nose, the airway doesn't seem to be actually opening up. So that's basically telling us that in spite of the airway being, nasopharyngeal airway being there is still significant obstructions happening below. So surgery may not be a right tool for him. So the real question is, does DICE-directed decision-making help in improving outcomes? And then there is a lot of literature supporting that. But there are certain findings that are associated with poor outcome. They are complete circumferential collapse, lateral velopharyngeal collapse, anteroposterior collapse at the tongue base, and supraglottic collapse are all findings that are associated with poor outcomes. So for example, this is a complete lateral collapse. This is a circumferential collapse happening at the level of the velum. This is a complete tongue-based collapse. As you can see, the whole tongue is just falling like a thick structure, causing a secondary epiglottic collapse. This is a poor outcome, a finding. Supraglottic collapse, like you would see in this. See how much redundant mucosa is there in the supraglottis causing an obstruction. So there are certain viable options in your in a surgeon's armamentarium to deal with these particular structures. A special mention about UARS in DICE. Again, there's a lot of research that is being done. UARS is something that we see nowadays. So a lot of study that needs to be done. For again, want of time, let me skip this. So we are all hoping that upper airway stimulation would shortly come in India, and this could be a game changer for us. But again, it's been around in the West for about 7 years now, and lots of studies have come out that, but this is not the holy grail. There are lots of problems with this as well, but there are a specific set of patients who would benefit from upper airway stimulation. Epiglottis is one of the unique attributes of drug-induced sleep endoscopy. Other evaluation techniques do not visualize the airway obstruction specifically related to epiglottis. This is a statement that Dr. Vijay doesn't agree with. We've had many discussions about it. I mean, dynamic MR can also equally pick up epiglottis. Anyway, that's a discussion for another time. So the current gold standard in optimizing obstructive sleep apnea treatment selection for upper airway surgery today is, I feel, drug-induced sleep endoscopy. Thank you very much for your patient listening.
Yeah.
Vijay, over to you.
Can you hear?
Yes.
Yeah, thank you very much, Kishore, for briefly discussing the DICE and various modality of doing it. So we will have questions, as I told you, we'll have questions at the end of the session, and along with the discussion, I think we'll be able to cover the questions also.
Sure.
Can we go into the panel?
Yeah.
Can you see the full screen?
Not yet. You need to go into slideshow.
Now?
Yes.
Okay. Fine. So we all know, as we have discussing for the past 2 days, OSA is a major challenge for physicians and healthcare system throughout the world. And because of the high prevalence and the impact on daily life, OSA obliges clinicians to offer effective and acceptable treatment options. So it is a common disease of both adult and pediatric age group with myriad of presentation. It's a spectrum of disorder and it is a metabolic syndrome. So that's why we all are here to diagnose and manage how we manage these patients, as it involves multiple specialty to manage this condition. So we have Dr. Rahul Modi, who is an ENT surgeon and sleep medicine from Dr. L.H. Hiranandani Hospital, Mumbai, and Dr. Sujit Rajan, consultant chest physician, Bombay Hospital and Medical Research Center from Mumbai, and Dr. Srinivas Kishore, Director of ENT AG Hospital, Hyderabad. I'm sure doesn't need much further introduction about all these international and national speakers. So directly we will go to case discussion. So case one, Mr. X, 54-year-old businessman who travels a lot with irregular sleep timings, social drinker come smoker, snoring with excessive daytime sleepiness, with disturbed sleep, with vivid dreams. No apneic spells observed by his spouse. So how do you proceed further from the clinical history? Anything more would you like to ask? I would start from Kishore.
Can you go back to the earlier slide, Vijay? Yeah. So EDS, I think, is one significant factor. This guy looks like a typical, what we now call as a garden variety of obstructive sleep apneic patient. So in terms of history, I think it's pretty clear as to, maybe I would probably ask him a few, whether he has nocturnal enuresis, or maybe that's the only thing that I would probably ask. And maybe I'll also ask if he has any calf pain or leg pain, or just to look into other comorbid conditions that may be associated with OSA, something like limb disorder. Okay. And that's extra probably what I would ask.
Rahul, would you like to ask anything more in the history to know any further details? Dr. Rahul?
Yeah, hi, Dr. Vijay. Hi. So, see, history is very key when we are looking at a patient with sleep apnea or any sleep disorder. So my history will start from, given his irregular sleep timings, I want to first document whether he's getting the quota of 8 hours every day. Because, the most common reason for EDS would be incomplete sleep in today's work from home, constantly on the screen 24/7 kind of an age. So that will be one. And I would like to get a handle on how bad the EDS is. Whether it is, whether it is more of a fatigue that he is masquerading as sleepiness, because, OSA is very good correlation with sleepiness, but the fatigue factor is something that I like to get into. And the other habits, does he tend to take alcohol? How frequently would he take that? Because his routine will give me a lot of clue as to how much my treatment might improve it and how much his lifestyle will improve it actually.
Exactly.
So those details I will need, and I'll be also try to, if there is, clinically, if I feel that, the symptoms don't match, if the EDS is very severe and he is not that kind of an obese guy, which will come into the examination part. But then I would also like to screen, actively for any hidden RLS symptoms. He is kind of just about in there. And for also any other, psychiatric issues, so much so as a stress part in terms of his work related, and what prompted him to visit a doctor, in the first place. Exactly. Need to get his motivation as to why is he come to a sleep clinic to get, things fixed for him. So those things will give me an idea as to how sincerely he will follow whatever I'm going to tell him. And
the most important part of the
yes, if it is pushed by his wife and nagged by his wife, then it is, or he's really serious about it and the EDS is really not letting him work and his routine is getting neglected and those things. That will give me a soft handle on as to how aggressively do I need to pursue this patient also further.
Exactly. So, Dr. Sujit, would you like to add some more?
I think Rahul summarized the history very well, Vijay. I think we really need to spend time there and understand if there's sleep deprivation.
Exactly.
I would have liked to know his weight, but I guess that will come soon on the future slides. Having said that, the last point you mentioned, no apneic spells observed, is a very important point against sleep apnea, actually. Because agitated arousals are probably the most important history that would be given by the sleeping partner. And
Yes,
that seems not to have been observed, which doesn't rule, of course, rule out a still possibility of sleep apnea. But that was important, I thought.
That's where I have also made the catch.
Yeah.
So apneic spells is basically observed, as you said, observed by the spouse or the partner, as he's traveling a lot and he may be sleeping alone or in different places. That may not be much important here. So basically, we would like to understand, as an ENT surgeon, we would like to know whether this patient is a OSA or any other sleep disorder. As Modi rightly said, irregular sleep timings and traveling with stress and all at this age, 54 year. So we have to rule out other part of the story. And also we would like to know what are the other possible options here. So here, as we said, we will have a detailed history. And then as you ask, the height and weight, the BMI is around 29.3 here. And no comorbidities, no nasal symptoms. And the clinical examination is obviously obese with mild DNS with inferior turbinate hypertrophy, oral cavity, lot of teeth marks on the tongue with FTP 3 and tonsil grade 2 with edematous palate and long uvula, and the external contour of nose and mandible, nothing specific, no retrognathia. So with this clinical examination, would you like to ask some more to understand whether this patient needs further examination or further investigation? What kind of investigation would you like to do?
Vijay, to the respiratory physician attending this, can you explain what is FTP and TG?
Okay. So when we look inside the oral cavity, it's a Friedman's tongue position. We would like to know how significant the obstruction could be in the oral cavity or the oral pharynx, and what is the relation of tonsil and the palate, the Friedman's tongue position.
So sorry to interject. I think for it's just a modified Malampati, Dr.
Okay,
Rajan.
okay,
It's modified Malampati.
Sure.
We give it a posher English name.
All right, good.
So tonsil grade is tonsil, how significant it is blocking the airways too.
Sure. And what is that? If you go to the last slide, Vijay, your tonsil grade was 2. So how big is that approximately?
So tonsil grade 2 is within the pillars.
Okay, within the pillars. All right.
If it is outside the pillar, it's 3. And if it is going to touch in midline, it's 4.
All right. Thank you.
Yeah. Anything else would you like to?
Yeah.
So here, as Dr. Rahul want to quantify the excessive daytime sleepiness, we can use Epo sleepiness scale. Or any other scale do you use or Epo sleepiness scale?
I think stop bang is a very good scale.
Stop bang?
Yeah, we do use stop bang. That's also been very well validated, actually. But Epworth sleepiness, I find, tends to overdiagnose more than underdiagnose. That's what my experience has been with it.
Okay.
And as Rahul rightly said, we get a lot of sleep-deprived patients who test very high scores on the ESS. So we have to be careful when you use it.
So 1 second before we shift to the next one, about the questionnaire, one point there, especially since we're talking about the stop bang. In fact, there is some data out there that, sometimes when you use this stop bang questionnaire that is necessarily being devised for the Western population,
yes,
we tend to lose out on the pickup rate. And hence, what they've done is a beautiful paper that's published by the anesthesia department from St. John's, wherein they actually reduce the neck circumference and the BMI just by 1 centimeter, and the BMI has been brought down. And then the moment that happened, the pickup rate suddenly increased, because we as Indians, we have a lot of other issues in terms of skeletal morphological problems, and also because of the central obesity. Our BMI may not be very high, but as all the other metabolic syndromes go, we are more vulnerable at very less BMI. So I think that stop bank needs to be modified for the Indian population. Then our strike rate will be much higher.
Sure. Having said that, I think a value more than 5 really increases the probability.
Yes,
but I agree with you. I agree with you. You could get a larger pool of patients diagnosed if you change those criteria. Yeah, in our population.
So the next thing is, as a ENT surgeons, we like to look inside the nose and inside the throat. So will you be, Kishore, will you be doing these OPs for all the patients as an OPD procedure, or will you select any specific patients?
All my patients get all these 3 things done as a part of a single exam. So I just do a flexible laryngopharyngoscopy right from the nose through down. So it gives 2 valid points. One is for us to sort of understand if there are any obvious static obstructions that are there that could actually affect the efficacy of the gold standard treatment if you were to give. Number 2, it will also sort of look for the patient, and you play the video, they could also understand how narrow their airway is or how deviated the septum is, if they're polyps, if they're adenoids, and lingual tonsil hypertrophy. They also would sort of understand. So it helps and it plays both ways, from a physician perspective and also from a patient perspective, to understand what's going on there.
Rahul?
So definitely, yeah. So
There is some echo from your mic. Is it so?
yeah,
I think, yeah.
So, I mean, all patients get an FLP for sure. Depending upon, how the clinic is going, I may postpone it sometimes after the sleep study also. But definitely before prescribing any kind of a CPAP trial, the patient will get an FLP evaluation to rule out for any significant obstructions for sure. So yes, at least an FLP. And if you do an FLP, we negate the use of a DNE or a VL scopy. And I feel FLP is a little more natural than the VL scopy because it gives that, the tongue position in a little more natural setting. When I'm doing a video laryngoscopy, I'm actually making the patient protrude the tongue out. So that will give me a very good picture of the larynx, but I'm more related in the nasopharyngeal and the oropharyngeal area, primarily when I'm looking for, sleep apnea per se. So VL scopy, actually, I would discourage from doing a VL scopy, like a rigid VL scopy. Go for a more, awake fiber optic kind of an evaluation.
Okay.
That is the preferred modality. So all patients, definitely yes, before a CPAP trial.
Will it change your, so obviously after the clinical examination and all those things, we would be suggesting him to go for a sleep study to assess the severity of OSA or any other sleep disorder. So will it change your option of doing a sleep study? This scope is
not really. Actually, I mean, one of the things in history that I like to also find out is if there is any immediately correctable. If the guy is having some acute rhinitis, some uncontrolled allergies, and those things, I will get it optimized. But an FLP will not change my sleep study indication. So a lot of time I do it, after the patient. I mean, it's a busy clinic. And, sometimes and practically what you do is you tell them, get the sleep study done. I think you require it. And then we'll talk further. Once the sleep study comes in, once I have the numbers in front of him, then I can tell, okay, let me just have a quick look into your airway.
Yeah.
Let me see how you're doing. And then we can, go for a CPAP trial. Occasionally, I would say, and we do see this, more often than we would like to acknowledge. You will see patients with a lot of polyps, and the patient is not very symptomatic for it. So you don't want and you can forewarn these patients. I mean, I have had a patient with a nasopharyngeal mass, which was almost undiagnosed, no other symptom. The patient was actually referred to me because the patient was not tolerating CPAP. So it's good to just kind of get it out of the way before the CPAP trial, and just to give a heads up to the patient that I think your nasal cavity is a little obstructed. Don't get too surprised if you find CPAP a little hard to adjust to, and just give them a heads up. Otherwise, they get taken by surprise that why didn't you tell me this before putting me on CPAP and all of that. So it's good to tell them, forewarn them, tell them it's going to be it may take 7 days, 15 days for you to get adjusted to the CPAP. So don't worry, give me a feedback, and then we take it forward from there. There's a lot of talking to the patient along with the scopy. I mean, getting their expectations correct.
So here I would like to ask Dr. Sujit, who is, I'm sure he may not be able to do an endoscopy, DNA and urescopy. How about, do you routinely do FLP or before doing CSP?
No, we don't actually. We followed Rahul's advice to try CPAP first before referring to the ENT surgeon, and that's why I usually do that. But this is very interesting, and I think we do have someone who does DICE at our hospital. And I think it makes so much sense, Vijay, to actually do it, because the whole conversation changes with the patient.
Exactly.
You're able to actually tell him what the expectations, what his expectations are from CPAP, and adapt your advice to that. Having said that, I'm just wondering if it was as straightforward as 3 nights of CPAP trial, the patient is doing well and wants to forget about meeting a surgeon, how should the conversation go in your opinion, Vijay? Because you have these patients who will say, look, I'm fine with CPAP, but I don't want to use CPAP lifetime. Okay, and I think that's where the conversation needs to begin, about probably doing DICE or FLE, or what should be the next step in someone who tells us we're great, we're awake now during the day, we're snoring less, the sleeping partner is happy, but don't tell me I have to use this lifetime because it's A, I'm not overweight, or B, I'm overweight and I'm not going to lose weight in a hurry. So what do you suggest?
Yeah,
exactly. Sorry to put the question back to you, but it's learning for me as well here.
Yeah, so that's where how to proceed further. So we will be evaluating further with a drug-induced sleep endoscopy or a dynamic MRI to see whether the level of obstruction and the component of obstruction, whether it is static or dynamic.
Okay.
So I always feel like discussing with my patient. It's like when there is a wax in the ear,
right? And
without checking that, doing a hearing test and then looking inside the ear and removing the wax. Oh, now my hearing has improved. Then
correct.
The value of audiogram hearing test is
absolutely makes complete sense.
Kind of differentiating the dynamic obstruction and the static obstruction component is very important before putting subjecting the patient for a sleep study or endoscopy, I feel.
And if you had to choose between DICE and a dynamic MRI, would there be a preference there? Because both would be expensive for the average patient.
Yes. So both has plus and minus.
Okay.
Both are complementary. And this is an interventional procedure. And that is, the patient can just go to the dynamic MRI, MRI gantry and get the test done. But there is an option of this is not a natural sleep, DICE.
Right.
Sleep MRI is a natural sleep if he can get into the proper sleep. Usually OSA patients get into sleep quickly. Okay. But still we prepare them with proper counseling and we send the patient to MRI gantry at late night in our specific MRI centers where they know what to take and when to take.
Sure.
So when the patient get slowly into sleep and when the patient is snoring, the technician takes the images. Thousands of images will be taken and made it into a short movie. It won't have that classical 24 frames per second kind of movie like drug-induced sleep endoscopy. The frames will be very short, maybe 4 to 5 frames per second kind of thing. So it runs a little faster than what we really expect in a dynamic MRI. So it looks like you won't get that classical 10 seconds apnea or 20 second, 30 second apnea. It will be much shorter. But the idea of a drug-induced sleep endoscopy or dynamic MRI is not to look for obstruction, that is a apnea or something like that. We want to know the pattern of obstruction. So what kind of collapse happening in the airway, whether it is lateral or anteroposterior kind of. So both are complementary, and rightly, as Kishore was saying, drug-induced sleep endoscopy picks up more of epiglottic collapse as we are directly looking at that. But dynamic MRI also, if you can look on the sagittal section, you can see the epiglottis, which is blocking the airway. But what really we can't see much in a dynamic MRI is further down, that is hypopharyngeal collapse, that is a aryepiglottic fold and laryngeal inlet collapse. All those can be nicely visualized in DICE. So both has to be ideally chosen for which patient you need which investigation. If it is a morbidly obese patient, subjecting them to a drug-induced sleep endoscopy may be a little risky, and we won't recommend for a beginners. Sometimes even it may end up in a tracheostomy. So that kind of thing we have to think before suggesting the patient for further investigation. Actually. Anything you'd like to add, Kishore or Modi?
It's amazing how this field has expanded, really. It's just amazing. Yeah. I don't know how many hospitals even do a dynamic MRI in the middle of the night. They use midazolam, Rahul, or what do they do?
No. This natural sleep.
Okay, natural sleep. Yeah, it's not easy to probably do it, right?
Yes. So again, the message is, so awake fiber optic should be kind of like, as many patients before, say, especially if you are in a multidisciplinary setting, prescribing the CPAP, not necessarily a DICE per se, before making every CPAP prescription. For patients who are not interested in continuing on CPAP, then perhaps DICE may be considered as a second step. So doing DICE before every prescription of CPAP, for CPAP failures, definitely, for people who are not tolerating, definitely. But a simple awake fiber optic, which hardly takes 10 minutes, we just spray lignocaine, put in the scope, and come out. It should not take long. Especially if you are not, getting the response that you're getting, it gives a lot of information very quickly.
Excellent.
Okay, so in this patient, we have done level 1 sleep study, as he doesn't have a apneic spell, he was telling, and a lot of sleep disturbance. So we suggested him level 1, and the total sleep time was around 281 minutes, that is less than 5 hours over a period of 6.5 hours study. And AHA is around 43 with RDA is 64, that means a lot of arousal index. And central apnea is not much, it is just 2. And the lowest saturation was around 76% LSAT. And the sleep efficiency is really poor and 64%. And the sleep latency is 46 minutes. Initially, he couldn't go into sleep. He was telling a lot of things was coming in my mind, so he couldn't get into sleep. And the REM latency is further which is almost 154 minutes. And it was REM duration is totally around 36 minutes only. So AHA 43 classically tells that he has apneic episodes, and arousal index is also good enough to say a lot of sleep disturbance is happening, and both is giving sleep disturbance, and excessive daytime sleepiness could be the reason for this. So anything else would you like to look in this sleep study?
Probably I would look for a T90 time. How much time this gentleman spent below 90% is something that I would be really interested. The second thing I would also like to know is any kind of a positional variation that's there in the AHI.
Exactly. Positional, I checked that. He was 90%. He was lying on the right side.
Right.
He
So
said,
all his.
I can't sleep. Yeah, he can't sleep in the supine position at all. So he asked me specifically. I said, okay, if you can sleep on the supine position, it would be good enough for us to understand more. But automatically he has turned to the right side after a few minutes once he got into sleep.
So this guy also classically, because of this poor sleep efficiency and sleep latency, he also probably has a lot of insomnia, which is a comorbid disorder with obstructive sleep apnea, which also we need to address simultaneously for this guy. And also probably I would also know among the AHI, which is a total score of about 43, I would like to know how much of them is real apneas and how much of them are hypopneas, just to sort of understand the disease burden on this particular gentleman.
Yeah, I don't remember exact value, but apneas are much more higher than hypopneas.
Fine, fair enough.
This
and
is
all are short durations.
Yeah.
Not very long apneas.
Yeah.
But still his saturation was around, the mean saturation is around 96 to 97. He could maintain it. And the lowest saturation is only 76.
Right.
How much time was he below 90, Vijay?
Sorry, I didn't have the sleep report.
No, but this is very severe sleep apnea despite a poor sleep efficiency, you know. So if this guy's REM sleep had increased, you would probably see an even worse situation. So it's probably comorbid sleep apnea with insomnia, bad insomnia. And so both will have to be addressed for him. Yes, absolutely.
Dr. Vijay, any particular reason you had done a level 1 study for him?
Usually my choice is when the patient has a lot of sleep disturbance where you will not be exactly know the total sleep time. I choose level 1. If for this patient, if I have done a level 3 and if I didn't know the total sleep time of 280 minutes, I would have calculated, or the machine would have calculated for 6 hours or 7 hours, that is 360 minutes or 420 minutes. Then the AHA will further go down. So whenever I feel the patient has a lot of sleep disturbance and poor sleep efficiency, I would choose level 1 so that I can pick up the right amount of AHI.
Sure. And there is a significant difference between the AHI and the RDI. Do you routinely do RERAs? Like do you do a PES monitoring for them?
Yes, yes. All our hospital, we don't do home studies. It's level 1 at the hospital.
No, but do you do like a esophageal manometry? How do
No.
But then how is the RERA so high?
So basically, I'm adding the arousal index.
Okay.
With the EEG value.
Okay. Makes sense. Right.
So, will you do DICE in these patients?
I mean, if I would, okay, so I'm just volunteering and I'm answering. I would definitely give him a CPAP trial, definitely, Vijay. But, I wouldn't really do a DICE because one, I'm in a corporate setup, so my practice may be a little different. I would definitely give this guy a CPAP primarily because we are looking at not a single, not a standalone OSA. There is significant comorbid insomnia. Number 2, I do understand that he's a businessman. He travels a lot, and his lifestyle doesn't suit the prescription of me giving him a CPAP. But I wouldn't really jump the gun and consider some, because if he is not compliant with CPAP and his compliance reports of CPAP are poor, then I would jump and do a DICE. Otherwise, I wouldn't do a DICE on this guy immediately.
Okay. Rahul?
So I think there's a lot of echo from Dr. Kishore's mic.
Oh, is it?
Yes, I think so, sir. Sorry.
No, that's fine.
Yeah.
Did you hear what I said? Or
No, I could hear what you said, but
there is echo, is it? Let me just try to.
No, now it's clear. I think Dr. Sujit's mic is echoing Rahul Modi's mic.
Okay.
Maybe both of them right.
Yeah. So for this patient now, I will be very strongly on the sleep hygiene part. I'm going to drill it down into him that he needs to kind of like, get the sleep hygiene in place. And, and counsel him a lot, because he's got some insomnia component definitely, and he may not tolerate the CPAP that well. However, I'll be very keen to know how much of his EDS actually reverses on the days that he uses a CPAP. How much of the EDS is actually reversing, because that will give me a clue as to should I look further for any other cause for EDS. If his EDS is not improving, even if he's using the CPAP well, then I like to, because he's primarily come to me for EDS. He's not come for the snoring part. He's come for the EDS part. So I need to get his EDS sorted. So a combination of sleep hygiene and CPAP. If that doesn't work, then I will actively work in looking for more causes, get probably a neuro consultation to get, look for any RLS or anything else that we can do to improve his, and once his EDS is in the way, I'm hoping he's using for CPAP for a few days. And once I'm clear that, I know how much of OS is responsible, only then I'll venture on into, DICE. But I'll be very reluctant. I mean, if he's not, because, he's got a very busy lifestyle to follow any kind of lifestyle modification. So it'll be some time before, it will not be before a couple of months before I'll even think of, putting him on DICE, unless and until he's really sincere. Alcohol, I'll be okay with him with the occasional intake, but if he's, taking 3 packs of alcohol every night to put him off to sleep and then putting on the CPAP, then I'll not be okay with it. But I think I should be okay with a moderate amount of alcohol, probably,
as a social drinker, we can accept.
Yeah. The social has to be defined very well, though. It can't, my social drinking and your social drinking may be very different. So that social drinking part needs to be a little bit defined for these guys. And weight loss, probably starting for whatever worth it is to talk to him about myofunctional therapy, just to get him on board, just to get him kind of like a little excited that, there is something else also. So use the CPAP for a few months, and then the tongue exercises probably help you. And then if everything goes along and there is nothing else and it's just sleep apnea alone, then we can think about doing a DICE and, thinking of some kind of a surgical intervention only at that point in time.
Fine. So the only one reason I have put the findings of DICE before starting this discussion on management is he was little, as he is from outside the state, he wants to know really what is happening in his airway, and before putting CPAP on him, he wants to evaluate his airway, whether there is any other option or that kind of situation. So as both the speakers rightly said, DICE is indicated in only very few patients when you are going to select the patient for surgery, or when the patient is finding it difficult to use CPAP, or in failure cases, surgery or CPAP failures. So in those particular situations, I think all of us will agree to that, the DICE indication. So anything else would you like to add, Dr. Sujit?
Nothing else, Vijay. I think that
discussion is almost. So, Kishore, what kind of surgery would you recommend in that DICE finding? Complete collapse at B-lump. You are mute. Yours is mute. You have to unmute.
Can we go back to the DICE finding then?
Yeah.
Because surgery will definitely depend upon DICE. And in fact, when you, in the next slide, you actually said CPAP titration. In fact, now there's a lot of data that shows that you can do CPAP titrations on DICE. And the data is very similar when you do a lab titration and a DICE titration. So anyway, coming back to this, circumferential collapse at the level of the velum is again an end product of his BMI being very high, because it has been attributed that higher BMIs are associated with more what we now call as CCC pattern, that is complete circumferential collapse. Now, the lateral collapse, again, at the oropharynx, is that a complete collapse? So that's a complete collapse at the oropharynx. And tonsil 2, right? If I'm not mistaken, tonsil 2, right?
Yes.
And AP complete collapse at the tongue base and secondary epiglottis collapse, which is a byproduct of the AP complete collapse from the tongue base. Now, assuming that this patient is, and how is the nose? Nose also has a significant septal deviation.
With the
Yes. So in fact, probably, I think what we should probably do is stage this guy's management, because again, it's a comorbid condition. We also know that a lot of upper airway obstruction can cause EDS. And that's why when you do a nasal surgery for sleep apnea patients, even though the respiratory parameters in terms of AHI don't change, subjectively, their quality of sleep improves. So in this patient, I would actually like to do a nasal surgery first and see how much with nasal surgery, weight loss, maybe MFT, and see if he actually improves. I wouldn't be very sort of trigger friendly and jump the gun and do any kind of a palatal or tongue-based surgery on him.
So
well, that's my take.
That's a important message I would say. Definitely, this guy is not a classical guy to choose for surgery, unless he is not able to tolerate CPAP, or when the pressure is very high, where he couldn't tolerate CPAP pressure. Dr. Sujit, would you like to add something on using CPAP in this patient to counsel him how to go about it? He is not much convinced of using CPAP. I have to put a lot of effort to convince him to use CPAP, because he was telling so many reasons. I'm traveling a lot. I can't be carrying CPAP. I'm going here, there, that city I will be staying. So all those reasons and excuses he was giving, he's promising me that I will reduce weight in few months, few weeks. So what is, how to tackle this patient when he is sitting in front of you?
So we would normally, Vijay, tell them, you know, a lot of patients look at the machine and get quite overwhelmed that they have to actually connect to a mask, a tube, and a machine at night. So reassuring them that this is just the air in their bedroom which is being delivered to their lung is, I think, the first priority, which is what we tell them, is that this is nothing but the air in your bedroom coming into your lung. And I think that sort of makes them understand that this is, I mean, they think they're on a ventilator. Some of them think they're on their last leg. And, you know, when they see the machine or they've seen someone else using it. So reassuring them that a lot of pharmacology that we have today and that we use in patients has far more side effects than CPAP is the first thing. And the second thing is, of course, when it comes to using it, the sleeping partner, of course, drives a lot of the discussions, because the snoring is very disturbing. Sometimes the bedrooms are no longer shared. And so I think counseling them on that part is equally important, as well as hypoxia. And I think COVID has given us an amazing opportunity when it comes to hypoxia to actually tell them, because they suddenly know what is normal oxygen saturation, which they never knew 2 years ago. And today, everyone's worried if their saturation goes down. And when they see the T90, you know, more than 5-10 minutes, I think it carries a lot more weightage than what it carried a few years ago. So using that little bit of help, unfortunately, due to COVID, we are able to convince many more patients to actually use the machine and then get on with their lives, because the whole purpose is to get on with their lives. Now, when they get on with their lives, they're not comfortable using it every night. They want discussions on alternatives. They're on the borderline. They have a moderate sleep apnea. I think that's the time the challenge. For me, the biggest challenges are mild and moderate sleep apnea. And I think that's where the role of surgery, even whether it's nasal would be significant, because you could actually tell them ways to cure it. Whereas each time they do the study, they land up with a mild to moderate AHI index, and they just don't want to use the machine regularly. To me, those are much more challenging patients than those who sleep like a baby with CPAP. So I don't know, in terms of moderate and mild sleep apnea, what the role, if this patient, for instance, do you see circumferential narrowing at the velum area in a patient with moderate sleep apnea? In that case, is that important thing to look for, Vijay? Would you think? Because then, of course, the counseling is different. But in terms of counseling for CPAP, it's necessary. And we tell them, look, this is necessary. This is not an addiction. Addiction is alcohol, tobacco, sedatives. Those are addiction. This is necessary, just like some people need a pair of glasses. You need to use your CPAP. Whether you need to use it lifelong, I never commit anyone to anything lifelong, actually, because lifelong means you are able to predict what's going to happen throughout their lives. And I think using that word, whether it's for inhaled steroids for asthma or nasal steroids for allergic rhinitis, is the wrong thing to use. So we tell them, I mean, I had a friend in Jaipur who used to tell all children with childhood asthma that their inhaled steroid is a 2-month course. And I never heard of this course anywhere in any guideline. But he said, no, that's the only way to get the patient back and have another conversation with the parents. And, so he was a pediatrician. He said, we need more conversations with the parents and children to ensure adherence and compliance. So now I think those conversations will also tend towards alternative treatments to CPAP. And I think that is the biggest change that needs to happen in a respiratory practice.
Dr. Vijay, you're on mute.
Kishore, would you like to add?
No, I think he's beautifully summed it up. I think that's fantastic. And to answer his question, whether do you see complete circumferential collapse in a mild to moderate sleep apnea? Yes, that can happen. A lot of it depends on the airway and the structure of the airway. And one more metric that we normally use that actually we forgot to mention is the occlusion. A dental arch analysis, the thyromental distance and the thyromental angle is also very important, especially for a skeletal patient. Lot of our patients are skeletal. They start off as childhood OSAs, they grow into adult OSA with the same kind of area behind the maxilla and behind the mandible. And these patients are the ones that also have these kind of very different anatomical pictures when we do sleep endoscopies.
That was the second case which I wanted to discuss today. Anyway, Dr. Rahul, would you like to?
Just a quick point, sir, to add to what Dr. Kishore said. Actually, there is good amount of data, sir, to tell that there is absolutely no correlation between surgical success rates and the pre-op AHI. So the pre-op AHI could be 110 and I can get a fantastic outcome if the anatomy is favorable, if the person is going to have a favorable anatomy, and I may get a very bad outcome in an AHI of 15. Because the anatomy is not favorable. So our decision making for surgery is never based on the AHI or the sleep study metrics. They tell us the need for therapy. If it is a mild AHI with not much oximetry changes, then I'm not worried about, him suffering a lot. But my treatment decision, especially for, surgery, upper airway surgery, whether skeletal or soft tissue, which depend entirely on how the morphology of the airways. Even if he's got a mild, even if he's got a severe, but I feel that the anatomy is very favorable, then, and this is all documented. I mean, there is a good amount of research to show this, that AHI has absolutely no impact. So the thought process and even the ASSM guidelines actually, I think, need a lot of change, because they have propagated this idea that mild AHI, you can go for a, oral appliance therapy, and moderate you can consider. For severe, we should not do surgery. Severe should only be, CPAP therapy. because the patient anatomy is what they're going to decide how the surgery is going to be out. More so that just the underlying point that just we take AHI as a guiding metric in terms of the severity of the disease, and one of the metrics, not the only metric, along with other reasons like how is the EDS going. Sometimes the EDS may be very high and the AHI may not be very high, and the surgical decision making is entirely based upon the anatomy of the patient. So for that reason, just that point.
So
Just
the
one
more,
question to
go ahead, Dr. Raj.
3 ENT surgeons here. Just one question. Is there any infrastructure that is absolutely essential? Because as respiratory physicians, we are dependent on our ENT surgeons at our hospital. Some of them profess interest in sleep apnea surgery, but are not adequately trained. And some of them are good at it. But, we have fiber optic laryngoscopy. I think that's available. DICE is also being done by a couple of people, but is there any other infrastructure we should be pushing our ENT surgeons to ensure is available at the hospital to evaluate these patients and manage them better? Functional MRI or, dynamic MRI?
Actually, we have in IASSA, in our association, we have a certified training program where Rahul Modi is in charge of that. And we do course like 2 months or 3 months training program in different centers. And as I told you, infrastructure as for dynamic MRI or DICE is the important modality. And other thing is lateral supplementary. And what we are all looking at now is a sleep board. Like to have, as you are in a multi-specialty hospital, definitely you can have a sleep board with your for other specialty colleagues like facial-maxillary, psychiatrist, pediatrician. So as he brought out myofunctional therapy. So basically it is a multidisciplinary teamwork.
Right.
And it's like a sleep board, like other oncology board kind of thing. If we can have a discussion, see, right now almost for more than 40-45 minutes, we are discussing about one patient which have been almost threaded out from clinical history to management. So like this, each and every patient, if you could discuss and brought out the risk management out of that discussion, definitely that will help the patient and improve the success rate.
I've seen the most important, the most important thing in this, Vijay, when you say sleep board, is there has to be one person who drives it. Because everyone is so occupied with their branch and in inverted commas, the easy stuff in the branch that they get distracted very easily with the volume of other patients that we have, So someone driving it and coordinating it and ensuring there is that clinic running, because otherwise you go to so many people who would call themselves sleep specialists because they can diagnose and treat OSA in a majority of patients. But there is a significant minority, not a small minority, I think, that could do with much more comprehensive care, as you said. And this course is very interesting. I would probably, it's open to respiratory physicians as well, young respiratory physicians who want to spend time on this.
Yes, of course.
Oh, excellent.
So, so my point, I would also like to, since you said that there are people who are doing DICE, sir, it's all about interpreting it.
Yes.
There is a learning curve, but it's not a very steep learning curve.
Sure.
This is something that even respiratory physicians see every day. You all are doing bronchoscopies left, right, and center,
right,
and putting stents everywhere nowadays. So I think this is something that is that even as a respiratory physician, you all can do. This is not something which is forbidden for, and it's only for one clinical subset. No, I think anybody can do it, but it's all about interpretation. And again, trying to identify which are the good outcome measures for surgery, which are the poor outcome measures for surgery. Absolutely. So that is what makes a difference.
No, it just adds another dimension to a sleep clinic, if you ask me.
Yes.
Because the sleep clinic never had this dimension for years immemorial. And I think the last 5 years, it's really caught up. It's really caught up. But yet, I think a lot of young respiratory physicians are not sensitized to much of this.
Correct. I mean, if you really go by just the interest and the number of papers that are published in DICE in the last 5 years, the
Yes.
graph is really high just by PubMed.
Amazing, amazing.
Fine.
Yeah.
So I think we should call it
Yes.
a day.
Yes.
Only one patient, one case, but that was a very detailed discussion with you all. And I would like to thank the ResMed for making this wonderful discussion. Thank you all the panelists and all the viewers. We will meet in some other program.
Thank you.
Thank
Thank
you
you,
so
Dr.
much.
Sujit. Thanks
Thank
for
you.
coming on board. It was a wonderful talk. It was fabulous.
Thank you, Chris Srinivas. See you, Rahul. Bye, Vijay.
Thank you.